Okay, my talk is just a real basic, simple talk about the development of the hip and maybe a few peculiarities which are important for you to know. Maybe there might be more relevance in pediatric orthopedics to some extent, but also maybe to the adult, especially the vascularity. Functionally, the hip joint is supposed to be a triaxial joint of the ball and socket type. As we all know, it moves in all spatial planes and derives stability actually intrinsically from the anatomy itself and the strong ligaments which are around the hip and the muscles around it. It's a the acetabulum is an hemispherical socket. The radius of curvature is usually about 2.7 centimeter. The labrum covers slightly more than 50% of the femoral head. So as we all know, the femoral head is not completely covered. Even when you do a total hip, you can see that most of the femoral head is uncovered. Horseshoe-shaped lunate socket and loads largely to the anterior and posterior. And it's, as you know, it's directed lateral, caudal, and anterior. And as you know, this will also influence what is called version of the acetabulum in the transverse plane. Femoral head is 2/3 of a sphere. It comes under the group like an ellipsoid. It's called formed like an oblate spheroid, supposedly. That means there are 3 axes. The 3rd axis is shorter than the 2 other axes. It's 5 centimeters in diameter. The center matches the center of the acetabulum. And the cartilage, the hyaline cartilage, is thickest at the central and anterior part. You also know that the fovea centralis, where the ligamentum teres is attached, and that does not have any articulation as such. And the blood supply of that artery is just transiently important. What about embryology? How does the hip develop? So at week 4, the limb field, the lateral plate mesodome starts to proliferate. And there, the proliferation causes the ectoderm to bulge out, and that is called the apical ectodermal ridge, and this is known as the limb bud. So you should remember that the upper limbs start a little bit earlier than the lower limbs, 4th week, and a little bit later is the lower limb. And they grow proximal distal and craniocaudal. Week 4, fibroblast growth factor induces formation of this AER, which then guides further development and proliferation and finally apoptosis to form the joint. There are lots more in this development. I kept it very simple. As you know, they're also dictated by homobox genes, TBX5 for the forelimb, TBX4 for the hind limb. And weeks 4 to 6, the lateral plate cells produce the cartilaginous and skeletal portions of the limb, and the myoderm cells produce the muscle components. So you can see that the limb buds really form very early in the fetal formation. By week 4 by 7, the hip joint develops from the cartilaginous end log. It develops a cleft between the precartilaginous cells which are programmed to form the femoral head and acetabulum. By week 8 to 11, the hip joint formation is almost complete or largely complete, and the femoral head is completely encircled by the acetabular cartilage. So if there is any insult between week 4 to 8, and that is when most of the congenital birth defects occur, like PFFD or radial club bands and fibula hemimelias and so on. So you can roughly even find which week or day of that initial part of the limb bud formation, whatever trigger happened to produce that kind of defect. Many of the organs in the body also develop at the same time. So as you know, all the preaxial hemimelias are associated with syndromes or problems with renal or cardiac defects. So because all happens at the same time. So something may be happening in all these areas. So we have still not unraveled all that part when it comes to syndromes. So this is just to show how at week 5, what it looks like, and at week 11, as you can see, week 5 and 11. What about at birth? At late gestation, the femoral head grows more rapidly than the acetabular cartilage. And at birth, the femoral head is also less than 50% covered, as you can almost see on this ultrasound scan. If you scan babies at birth, you'll probably find instability in all of them. And that's one of the reasons you try not to scan them until at least 2 weeks later, because especially for girls, there's the influence of the hormone relaxin and so on. So you have to wait until then just to make sure that you don't get some false positives. The acetabulum is also at its most shallow and most lax, like I mentioned earlier, and possibly it's also to maximize hip range of motion, which facilitates the delivery process. And therefore, the hip is uncontained in extension and adduction, reflecting the hip shallowness. So probably that's where the breech part of it may be also producing the influence of lack of development at that point for DDH. Okay, coming to ossification, the femoral head ossification center usually is 4 to 7 months. This is based on an X-ray. But for those who are doing scanning hips, you can even find that even as early as 6 weeks. So you can see the ossific nucleus quite early. There's a combination of appositional growth of the epiphysis on the surface and growth of proximal femur at the junction of the cartilaginous proximal femur and the femoral shaft. And I'll just come to the peculiarity of the growth plates. We were always taught that there is one growth plate at the top and there's one growth plate at the femur, and you got the growth plate of the trochanter, which is actually an apophysis, which does not take part in longitudinal growth, but it just gives attachment. But if you look at this picture, and I'll talk to you through some examples, though I haven't put some example, you can see how at birth the chondroosseous cartilage is all growing from one part. So the trochanter and even the femoral head comes from the same area of growth. Ossific nucleus by the age of 6, and then you start to see the growth plate going that way, and by the age of 18 to 24 months, when we look at the X-ray or when we look at a cross-sectional specimen, you see almost that is the growth plate. But actually what you don't appreciate is this part, and that is actually also a growth plate. So when you look at avian in children, when you classify, whichever classification you use, Kalamchi or whatever, type 2, you will see that is the growth plate which is affected because of the vascularity, and you'll see that usually between the age of 7 to 11, and then you'll get a valgus neck or a valgus head or what's called caput valgum and so on. So this knowledge of this becomes quite important. When you do DDH surgery and you follow up, you'll usually see the growth plate at the top end. If you want to see whether there's a growth or not, you can see this part very clearly and you can follow that up easily. The shaft of the femur ossifies in utero at 7th week. Greater trochanter, we talked about it, ossifies 2 to 4 years, and this is one of the reasons why in children your LPFA can be abnormal all the time. So you have to take that into account. So you may have to use neck shaft angle because of that. So until you, and we generally say that trochanter finishes growth by the age of 9, and if you want to do trochanteric transfers, age 9 possibly is a better time to do that. If you want to stop it from growing or temporary epiphysiodesis, like in Perthes from Benjamin Joseph's experience, he'll usually, when he does a varus osteotomy, he also does a apophysiodesis. It's not an epiphysiodesis, it's an apophysiodesis of the trochanter. Lesser trochanter ossifies quite late. As you can see, it's in and around 10 to 12 years. What about the neck shaft angle? It's not the same from birth. Okay, so at birth it's quite valgus, 150 degrees, and it goes on over time, and these are all normal values which are available from the books. And at adult, I mean, though normal is around 127, but you've got your standard deviation from 120 to 135 degrees at 2 standard deviation normal. What about anteversion? So all babies at birth are all normal babies at birth have got an anteversion of 40 degrees, and gradually this anteversion remodels to an adult 16 years of 16 degrees. But generally, most of the remodeling is done by age 9, and if you want to do any derotational osteotomies, possibly age 9 is the best factor. Now also remember, if you are doing derotational osteotomies in DDH in younger age, and you're also doing acetabulum procedure, you do not correct the femoral anteversion to that. You should correct to the age norm value. Okay, that's very important. Otherwise, you might get the hip dislocated at the back. So that's a very important clinical point. So this is just to show it schematic. Yeah. Where our children have retroversion at birth, classically is PFFDs and congenital short femur. They're all retroverted. So that's one condition for you to realize. They don't have anteversion, they have excessive external rotation and no or very little internal rotation. Pelvis. Ossification is in 8 weeks in utero in the ileum. Ischium is 4 to 6 months, are all in utero, as you can see. And at birth, the acetabulum is all composed of cartilage, and the hyaline cartilage of the trilated cartilage is all in continuum with the acetabulum. And the thin rim of fibrocartilage at the end finally forms the labrum. Now, we generally think that majority of the acetabulum shape development is determined by the age of 8 years. This was published by the good work of Harris, Bill Harris. But there are people who say most of the growth does occur by age 4, and I use age 4 purely because if acetabular dysplasia is still there till age 4, and if you want to correct all of it, then it is better because it's just preschool, so it's the least effect on your family life. So, and it's easier for a mother to take care of a spica at that age than you do a big procedure at age 8. So sometimes, yes, you need to know all this, but you may have to use other reasons why you can justify a certain procedure at a certain age. Late development is enhanced by growth of secondary ossification centers, which I'll go through next, and they will also increase the capacity of the acetabulum. So you can get late acetabular dysplasia purely because of failure of those ossific nuclei not ossifying. So, and that usually is seen sometimes in strong family history of acetabular dysplasia, you will see late dysplasia and late subluxation. And also, there is the whole development of the hip is also influenced by mechanical forces. If your hip was not centered, then your development of the acetabulum, secondly, does not develop as well. So the dysplasia becomes even worse. So the os acetabulum, which is at the anterior wall, is part of the pubis, is seen and develops at 8 years. The acetabular epiphysis superiorly, as part of the ileum, is 8 years. There's one posteriorly that is seen at 9 years. And all these will finally be responsible, the final contours of the acetabulum, because all these until then are in cartilage and you do not see them. And as you see now, it is from in utero to now, you can see a well-formed acetabulum all around. What about ligaments? All of you know the strongest of strong ligaments, the Bigelow's ligament, the anterior iliofemoral with the 2 bands. And there are other ligaments, and these are all gives extreme stability. So dislocations of hips are not that common. We do see them, but it's quite difficult to dislocate them, partly because of this intrinsic structure as well as these ligaments. You will have some important points coming up later on when the speakers are going to talk on periacetabular osteotomies and tonus osteotomies, the significance of the sacrotuberous ligaments at the back, especially when you do your tonus and so on, where the cut should be, how we'll prevent it from sort of redirecting the acetabulum. So the knowledge of all this becomes important, especially when you start going to the areas of pelvic osteotomies in the young adult. What about hip joint motors? I mean, there are 22 muscles, there are quite a lot of muscles. And, as you know, the common ones, the flexors, we always think of the psoas, which is the most important, or the iliopsoas. There are others which all cross the hip joint. They also are flexors, extensors, as you see, maximus, but there are your hamstrings which also cross the hip. The adductors, again the magnus, longus, brevis, gracilis, and the abductors, which are extremely important, and respecting them in your surgical approaches is so important, so that the more insult you do to them, the more is a chance of heterotopic ossification. The multiply operated ones later have, they do not work well, they get Trendelenburg and so on. So even your soft tissues become very important in your surgical technique. And the external rotators. Now also remember, these external rotators are all in areas where the blood vessels and the anastomosis are all around. So knowledge of those small muscles are extremely important, especially when you do surgical dislocation of the hip, and I'm sure there will be at least 1 or 2 speakers who later on will talk about it again, and some of those pictures may keep coming up again and again. So the vascularity to the hip is predominantly from the lateral and medial femoral circumflex arteries. They both arise from the profunda femori. And there are other little arteries, the acetabular artery, inferior gluteal artery, and superior gluteal artery. There is an extracapsular anastomosis around the trochanteric area. It was well described, goes by the name of anastomosis of Trueta. And then Chung later described the subretinacular intracapsular anastomosis of Chung becomes very important, especially when you use surgical dislocation principle. Now, both vessels are susceptible to injury. As you know, the medial femoral circumflex in a medial approach to the hip. You can also get it to the anterior approach, but possibly more so. Maybe that's why the AVN in medial approach is higher in DDH, though there are a lot of people who are still proponents of that. The inner anastomosis is subretinacular, is only covered by periosteum and synovium, and you have to be quite delicate when you do surgical dislocation, especially in slipped capitofemoral epiphysis, when you elevate it off and dislocate, so that you make sure that that part is maintained throughout. Just to show you some schematic pictures from the front. So you have your profunda femoris here, as they all shown there for you, and the circumflex going around. There and there. So this usually you'll pick it up in your bikini approach. You will see the ascending branch of the lateral femoral circumflex. Okay, these are the classic pictures since Gantz's dissections and initial research into his trochanteric flip osteotomy. And most speakers will have this slide all the time to show you how these internal branches and even the branches to the trochanter, how you have to respect it during the procedure. And this one, where just to show you that once you've released the shot externally apart from the obturator externus, and when you carefully dislocate it, you still maintain that blood vessel at the back quite well without producing any compromise. But you have to be careful at all times when you do a surgical dislocation to make sure those vessels are all intact and not, sort of kept tight or taut. Just a little test for anyone. What condition this could be? Pardon? Post-septic bilateral could be rarer. Pardon? Perthes disease. Bilateral small heads, no. Slipped, no. Sorry, it's all irrelevant to what I taught. So anatomy of the vascular. Okay, no, okay. So that can be, but that is extreme, very rarely. But this is something you see in post-meningococcal growth arrest, and you never see this until the age of 7 to 9, and you'll only be looking at the limbs, and suddenly one day you see what's going on at the hip. And when you take a mechanical axis view and suddenly realize, and that's what. So if you see now, one is complete growth arrest with a short neck, coxa breva, with a look at the trochanter. So what's your deformity analysis going to be here now? How are you going to use the tip of trochanter? So you can't use the tip of trochanter. I thought I'll put this just to sort of, this is an extremely valgus, but let's look at the CT of, no, I haven't got the CT. But this is what will happen actually. This is a type 2 growth arrest. So you got severe valgus, and then the head is also posterior and the trochanter is overgrown. So just to let you know, so some of the diseases you may not see it at this right in the beginning, you might see later on. A few simple facts for all of you to know. The hip joints carries around 2.5 times body weight during walking at 1.5 meters per second. And during the push-off phase, it goes to 5.2 times your body weight. When skiing on flat slopes, 4.1. So lots of forces going on. Whereas when skiing on steep slope, it's almost 7.8. So I think it is important for you to know how that little ball of hip and the socket can manage so much of your body weight through that cartilage. So it's amazing. And just to show you a final slide, the load distribution, as you can see, it is predominantly in that zone. And that on X-ray matches your acetabular-social. So the acetabular-social will reflect actually a load-bearing pattern, and any change in the shape of your social or the arch, the Gothic arch they call it, and if you know about it, you can read that article on the Gothic arch. That tells you lots of information about secondary, how the hip is loading, and this is how it loads. This is just to show you in sort of a cross-sectional thing. So the whole, as you know, all the compression and tensile trabeculae of the femur and how load goes through that, and that's your principal area of strain for the healthy femur. Thank you.